We're at the 25th Conference on Retrovirus and Opportunistic Infections, and I appreciate the opportunity once again to visit with Kevin McCock, who is from Kenya, with the CDC in Kenya, and you've been a lot of different positions over the years. But you were the first one that I think I ever interviewed for this project, and that was 150 years ago. Well, maybe more like 20 or something like that. But it was a very grim days. Those are the grim days, and we didn't have anything. And then there was the days where we talked about, well, you can't give people in Africa drugs because they're not going to have watches to time the drug. Remember, the drugs were then Q8, Q8. So those days went by, and we said, wait a minute, these people are better at treatment in HIV antivirals than they are in the United States. And then we said, wait a minute, we need to treat these people. And then the foundations and everything kicked in. So tell us more about that and how we got where we're at today. If you can give the brief history of HIV.
Yeah, well, good to see you, Fred, once again. I should point out that comment, that unfortunate comment about, we can't use these drugs in Africa because people can't tell the time. Yeah. That was not a universally held view by any means, and it was
by people that probably didn't want to spend the money.
It was a rather unfortunate comment by one senior individual. But in fact, yes, by using what was called the public health approach and simplifying, decentralizing treatment and treatment delivery, and using very standardized approaches with initially minimal laboratory monitoring. That's really how the program scaled up initially. And a lot has happened since then. A lot of development has happened. There is more access to laboratory capacity than there used to be. Viral load testing is now practiced very widely, actually influences patient management. So there's been a lot of success. But it remains a formidable problem. And as you said, in our earlier conversation, you mentioned 90-90-90, this global aspiration of ensuring that 90% of infected people know their status, that 90% of those access antiretroviral therapy, and that 90% of those are virally suppressed. We're not there yet, and it's not as easy as it sounds. And there's two groups that are particularly difficult to ensure access in, and that's it's men overall and young women. So adolescents and men are difficult groups, and we're not doing very well there. So it's still a lot of work to do, but at the same time, great progress has been made.
I think the 90-90-90 was presumed to be the answer, if you can achieve it, to have, instead of increasing, decreasing incidence of HIV, which is obviously what we're after, because once that happens, you can go to, well, they say zero, but this is no new infections would be wonderful, but less new infections would be the way to.
Yeah, and the concept is treat everybody who's infected, or the vast majority, get viral load across the community suppressed. People will be less infectious, and you should have less transmission. And there is evidence that that is happening, but we're not at enough scale. There was good data from, there's been data from different countries, from South Africa, from Uganda, and we have evidence from Kenya. Actually, we have a paper coming out quite soon in Lancet HIV that shows reducing incidence over the past few years in Western Kenya, around Lake Victoria. Reducing incidence in the face of increasing antiretroviral therapy access and uptake of male circumcision as a prevention strategy as well. There was an interesting paper, a slightly worrying paper at this meeting from South Africa, where it was shown that incidence in men in KwaZulu-Natal had declined, but in women actually had not, and in fact it slightly increased. And the explanation given was that women were very good at taking it, their uptake of antiretroviral therapy was better, because often they access therapy often in the context of pregnancy and prevention of mother-to-child transmission. And so the higher uptake in women was actually protective against transmission to the men. But the men's uptake was lower and not enough to prevent to lower the incidence in women. It's sort of a strange,
Well, and
worrying finding.
there it's not like presumably a men's disease in Africa. It's 50-50 or roughly.
It's actually there are more women infected than men, in fact.
Oh, really?
But it's heterosexually transmitted. Yes.
I also noticed, well, we did talk with one of the folks on our interviews from the CDC on the clusters, which is really probably the way to go. At least if you have limited resources, or for any reason you have to decide where you're going to spend resources, clusters are where you might want to determine are areas that you need to address more vigorously.
And that's been one of the interesting themes of this meeting this time is a lot of presentations and a lot of discussion around the use of phylogenetic analysis. In other words, molecular analyses of networks showing which infections are linked. The advantage of doing that kind of work is not to point that A infected B, which can be a hazardous discussion and a difficult one, and with lots of room for error, but to show where active transmission is going on so that you can target resources to those particular areas.
So I'm hopeful that have you determined where your next position will be? I mean, we talked about that earlier. You can only be so long in one location.
That's true.
Once you can become too adapted to
that's
how awful would that be? Right? You have a fondness for Kenya, though. Don't you?
I have been in and out of Kenya a lot, and I have attachments in Kenya. Yes,
Yeah.
So no, I'm not quite sure where I'll be a year from now, but we'll.
But you'll be back here at the CROI.
I hope so.
Well, we always appreciate the work that you've done, because we've talked over the years how we could do this archive of video, and I think we have to dig them all out at some point and play how the enthusiasm and the improvements and all that seemed to materialize, and we were always more hopeful. I mean, we always had that sense of hope at the end of a conversation that there will be better days.
Yes, yes.
And there will be continue to be better days.
I think the optimists have it.
Yeah.
Although the road is sometimes rocky.
And if only we could come up with a cure. We're not going to put all our eggs in that basket, though.
I don't think so.
We definitely have
there's a lot of one can make analogies with other difficult infectious diseases where we've made progress, but we have not eliminated them. Tuberculosis, malaria, syphilis.
So that was always equal with the people. We'd want to talk about AIDS and so forth. People from Africa in these conferences, and they'd say, "Well, what about TB and malaria? This is what we really worry about." And the people there worry about that more than HIV, because I guess when you get TB, if you're acutely infected, quickly, you're going to exhibit symptoms, and HIV, that's one of the challenges, I guess, in the youth in Africa, is that they don't seem to see their friends or themselves getting sick, so they think it's not real. I couldn't have it, so because I don't show symptoms, I don't look sick. So we really have to come up with the training and the educational programs that will reveal that just because you look good doesn't mean you're not infected. It's like many diseases are like that, but HIV can linger for years before, and those people are, like you said, infectious.
It's a formidable problem.
So we really have to address that.
We've done a lot, but there's a lot that remains to be done.
Good. Well, thank you so much for your time.
Good to see you again,
and I
Fred.
appreciate
Take care.
your energy, and keep on keeping on, as they say.
Thank you.